This being the stuff from I think it's based on the Noi group, and this is called it's Pain Revolution. So if you guys are working in rural Australia, I would strongly encourage you to apply. Being a local pain clinician or setting up your own local pain collective, you get a grant to study pain certificate. I can post some details in the chat. It's a weird course called the Pain Certificates course. And it's over at Uni of South Australia. It's been absolutely fantastic, and it was so practical. It went for about 6 to 12 months, but it was super achievable for me to do. So they provided you to do that course, and then we set up our own collective, and then hopefully you guys then teach other people to help break down barriers of pain, and we can get more clinicians who understand pain, feel comfortable and confident talking about pain. And then we kind of slowly have a pain revolution that way. So that's kind of the goal of the group. And I've just set mine up online because I'm mindful it's tricky to come to a doctor's clinic after hours. And I don't know, I feel like it would mean that there's a lot of people who actually can't make it. So that's what this is. So today our session, and I'm just going to start to share screens, is about, sorry guys, as I do this. We're jumping into week 2. I just want to acknowledge where I am. So pain, we are doing persistent pain, and tonight we're working on it overprotects us and prevents us from recovery. So each of these sessions, we're going to be jumping into some of the pain facts that the Pain Revolution team have put together. And before we jump in, Pain Revolution always likes us to acknowledge where we are from, and also to an acknowledgement of country. So I'm on the Wadawurrung land. Australia's been made of all these beautiful diverse communities, and we would like to pay respect to our elders past and present. Tonight, for full transparency, I have received a scholarship from Pain Revolution for the course, and it is supported by Uni of Australia. You guys should do it if you're really interested. And I also do work in the pain field. I'm just now in Musk. I have had a job in public health, working in community health, and I've done that for maybe 10 years, but now probably moved over to more private practice, and I'm mostly working with EDS, bendy people, TMJ, lots of people in persistent pain. So our goal is to start a better conversation. I think that's all the bits and pieces. These are all the 4 facts we're going to go through over the next couple of weeks. Tonight, we're going to get into the nitty-gritty that pain overprotects us and prevents us from recovery. I'm mindful most of us are clinicians. Probably if you guys want to just quickly go around the room and introduce yourself while we all are here. I'm mindful we probably will do this a few times. I'm just going to stop presenting. Whoops. Maybe that won't work. Who wants to start? If you guys can see my screen here, hopefully, is that still working? Can you see each other? Yeah, sure. Janine, would you like to go first? I feel like we're...
Sure. Sorry, I don't have a camera that's working at the moment, but hello, okay. I'm Janine. I'm a chiropractor and an acupuncturist over in Perth, Western Australia. I have a really special interest in pain and complex, cool, nerdy sort of stuff. I'm actually doing my Master's in Pain Management through University of Sydney at the moment.
Great course.
So I've only just started. I've just finished my first semester and only did 1 unit per semester. But I saw this, and I've spoken to a few people who have done the course through Uni SA, and that was one that I'd sort of tossed up with doing as well. So I was really keen to sort of see what you guys have done, because it seems really practical.
Yes, and that's what I want to make this as practical as possible, because you could do lots of beautiful courses and then come out and be like, I can't do this with my clients. Especially, I don't know, Janine, how long are your appointments working as a chiro?
It varies. Like a quick appointment would be 15 minutes, but longer ones either 30 or 45 minutes.
Yeah, which is hard to give high quality pain education while you're doing your stuff. So yeah, tricky. Monique, go for it.
So I'm a physio by trade, physiotherapist, and I later trained in lots of short courses to do pelvic health. So yeah, I'm in private practice at the moment, seeing anything from bladder, bowel dysfunction, pregnancy, postpartum, prostatectomy. Yeah, so I see a lot of pelvic pain stuff, and we're kind of getting to the point where I love manual therapy, so I do a lot of manual therapy. But then there's this part where you got to address the long-term pain. So yeah, so I'm like, oh, I just need some tangible things, and to kind of understand it more so I can get them to understand it, and then get them back to activities that they want to do. Yeah.
And I think, Monique, we've been told, especially with like the famous people online telling us, like Adam Meakin saying like, don't do hands-on therapy, or manual therapy is crap. So we've really moved away from that. But I am still a hands-on clinician who's still evidence-based and still knows and integrates my therapy a lot with pain education. So I feel like both can be true at the same time.
Yes.
It's very easy to get clicks being really negative on social media. It's really sad, but the stuff that does most well for me is like when I feel like it's a case study and someone's missed something.
Yeah.
And as a clinician, I don't even care if someone's missed. Like, that's not at all my remit, but it's what probably gets the most views and the most reach. So I feel like there's an echo chamber of that, but both can be true at the same time. Just because you do hands-on doesn't mean you're not a good pain clinician.
Yeah.
It's not what we're told, but I feel like that's really true. And that's what the more I've learned about persistent pain, the more still you can do your manual therapy, and there is a time and a place for it. Yeah. And Danny, go for it. I feel like you're our international
representative.
Yeah.
So I'm very glamorous. I'm from Scotland. So yeah, and it's come up with part of my address is my name. I'm too scared to try and change it in case I get cut off. So I'll just leave it as that. And I was saying to Jess before you guys came, so I'm just in between jobs. I have just worked NHS for 14 years since I qualified, and just starting to question things a bit more. So I handed my notice in 3 months ago. So I actually have applied for a visa to come out to Australia. I'm just waiting for that to be processed. And I'm just fascinated by pain. So I've done some studying on my own, and then I just came across this on Instagram. So here I am, I guess. Just what I can pick up. And I was saying to Jess as well, a few things have just sort of fallen into place since I handed my notice in. So I feel I'm meant to be here anyway.
Yeah. Well, happy to have you all.
Thank you.
Tonight this sounds a bit woo-woo, but tonight is about hope. So what I mean by that, and I just hopefully keep letting people come into this, people waiting to join. Sorry, mate. I am just trying to make sure that everyone can keep coming in. So tonight is about hope and giving people hope that although they've been in pain for a really long time, they can still change it. So the way that we go through hope, now this lecture is being filmed by Lorimer Mosley. So if you want the lecture straight from the horse's mouth, go back I'll just help you navigate it here. School is not the most easy platform to navigate, but if you guys ever do want to come into courses, this here is a free course here. The clinical Pilates and advanced Pilates skills are courses that we'll release later for we'll do those. They won't be free, but here is I'm really passionate about access to education for pain. So these are all free, and these have all been filmed by Lorimer. So if you do want more information, go back and watch these. And also too, I can also add some more resources. So there's some really good YouTubes that we can direct you to. So things like Tame the Beast, Why Things Hurt, and I'll put in another few links here which you can go back to and either watch yourself, watch with a junior clinician, or also to, if it's the right person at the right time and you feel like it's going to be absorbed, then send them to clients as well. I do that every now and again. So that's how you get access to these. And then if you did want to go through this lecture slide for slide, it's in here. I thought tonight it would be more valuable to keep this as practical as possible. So tonight is about hope. Last week, we went through the Twin Peaks model and looked at tissue tolerance. And so this is generally the normal relationship with pain. Pain provides a safety buffer to prevent injury. It's trying to protect. But tonight, we're going to go all the way down here. The Noy group love the neurotag model. which we do learn in depth in that South Australian course. I'd be so curious to know how you're finding the Masters of Sydney, because they teach, there's kind of like these two worlds of like pain education and pain theory. It's all kind of the same, but there are two separate cohorts in Australia that produce a lot of research on this. So a lot of the time people will say, I'm in the Noy group or I'm in the other O'Sullivan kind of group. Again, if there was like ever beef in the pain world. I don't think like that. I just keep thinking these are all tools that we could use depending on who's going to walk into the door. So pain promotes healing. Inflammation is expanding our safety buffer. Again, I think of this as SIMS, so safety in movement or danger, or safety in me or danger in me. Our body is just trying to protect ourselves, and I think of this as a dial of sensitivity, so it's dialed right up to try and protect us. Tonight, we're going to go through 2 practical applications that we can teach a client. I thought we could go into DIMS and SIMS, because I feel like that's a really helpful one that you can collaborate with a client with. And then also too, we're going to go into the cup model. I don't know, has anyone heard these? I can't see you. So if you tell me if you've heard them, like, has anyone heard of these 2 types of models to explain pain?
Sorry.
Yeah, go for it.
You go, Dal.
Oh, I was just going to, I'm working my way through the Explain Pain Supercharge book. So I've just come across some in there.
Yes,
I
nice.
haven't used them practically myself.
Yep. Monique, have you cups and like the dial or the DIMS and SIMS?
Yeah, definitely DIMS and SIMS. I find that quite easy to apply to like the person. The cups, is that like spoons? I don't know.
Kind of.
I
Or
heard
I think
of cups.
the cup like allostatic load. Similar, I have used spoons in the past. That's the spoon theory for people who are neurodiverse. Often that's something that they've heard or they've read before, that I've run out of spoons.
Yeah, okay.
The cup, I can go through and show you how I draw that out with a client. Have you guys also, Janine or Rachel, have you heard of the cup, or have you used these analogies in the past?
Yeah, I use the cup a bit. Is that the Greg Lehman sort of
I
analogy?
think so. Yeah.
Yeah.
And like what things are filling up. I'll go through the model and just you can tell me if like yes, that's the same or different.
Yep. Sure.
Nice one. And you, Rachel, have you used any of those before?
Oh no, I haven't. They're both like pretty unfamiliar to me, so keen to learn a bit more.
Nice. This here is, I call this the cliff model. We went through this one last week. So this is like trying to protect you from the cliff. So again, go back through that at the lecture, but going to, talk about hope tonight and how we can explain hope through pain. So I'm mindful, last week I got you all to have a piece of paper and a pen. So same thing again tonight. You can rustle around or put it in a notes. I want you to write down what you think bioplasticity is. And I want you just to have a quiet conversation with yourself. Do you ever talk about bioplasticity in your clinic room? All right. For those playing at home, bioplasticity is the ability of our cells and tissues to change. It's exactly the same as neuroplasticity, but bio, we're thinking about brains, nerves, immune system. It's like actually what we do when we heal, skin, bone, muscles, fat, all of this stuff. And this is how sometimes I might sell hope. It's weird saying I'm going to sell hope, but I do. I sell hope to a client. So I'm saying our bodies are amazing. Bioplasticity can dial up your symptoms, but they can also dial down your symptoms. So it's learning a new skill. It's getting weaker when you have bed rest. It's becoming stiffer when you do less. Like these are all things that people can understand. It's your bones changing shape. We run a really strong osteoporosis, osteopenia program in our private practice, and we see people's bones changing, but it's also from the opposite way if they don't do bone adaptation. Bioplasticity is developing habits. It's getting immunity from a virus. Learning how to go on a date again. I don't know who put that in. Your brain like worry more or become stickier to worry. Developing a callus, getting fitter. So people understand this concept and that it can either work for us or work against us. So it can be helpful and it can also be harmful depending on the inputs that we put into the system. So it can develop hypersensitivity, but also just if one thing is true, so is the other, it can also reduce hypersensitivity. So this makes me so excited. And often I always think about body language and my delivery when I'm talking to people who are on persistent pain. Often, and I'm a naturally excited person, but I will lean forward, my intonation goes up, I use my hands and I become bigger when I'm talking about they have control. And often I might deliberately make myself smaller as I can say, hey, and I might turn off my body language. I don't know how much it helps in terms of people understanding or carrying knowledge, but I just know that auditory, people are generally only taking about 10% of what we say. It's how they make them feel in the session that generally will help them change. And often I'm trying to do that in any way I can. Body language, my voice, the volume of my voice and speed, and also to how I'm using my body to educate them. So these are things that some clinicians think about, but the psychology of us in the room with the client and also how we carry ourselves, because I also feel like can be contagious. And that doesn't mean that you need to mask and put on a front all the time, but find what is authentically true for you. And also, I want you to start to reflect on how you are communicating this stuff with the client. Because if I monotone this and be like, yeah, you can change everything, it doesn't really sell hope to someone if I'm monotone and I'm just spurting facts, which especially junior clinicians or when we feel a bit uncomfortable ourselves, we are often, when we come into health, we are often generally pretty book smart people because we've had to go through university, and often when we get uncomfortable, often not always, we'll go into more theoretical stuff, we'll spurt out jargon, and we also might increase our level of our education or vocabulary. So we'll go back to the words that we learned at university without giving an explanation. Does anyone else notice if they do this? I don't, maybe not. Especially like just say if you don't know what's going on, you're like kind of trying to, I don't know, I remember when I was trying to explain non-specific lower back pain to a client, I was going into all sorts of things like creep and physics. And so I just found myself becoming more academic as I just didn't have the language to explain it to people. But coming back to this point is bioplasticity. I want you to start to think about bringing it up with a client, and this could be a potential in. I think of these analogies or education ways to help them understand pain as potentials to get in to change sticky beliefs. It's a weird analogy, but I always think about it like each time I meet someone, I have the opportunity to change how they feel about their body. So it's like knocking on a door. Sometimes they're really receptive and they open and I get to come in and really start to rummage and change things around the house. Other times they're fixed, shut down, or sometimes, I don't know if you guys have been in a session where someone gives you blank face, like you try and they just give you nothing. It's like the roller doors and the security alarm have gone down on the house and you're just like, oh, I feel like I should, anyway, run away. So what I am hoping that the more strategies, tools, or ins you have, then you can match it to the right person. And also, when you are delivering education, you're aware or cognizant of the energy that you bring and how much hope you are selling, especially if someone is right in that valley of despair and they're starting just to feel absolutely hopeless. It is unhelpful for me to sell toxic positivity and be like, oh, mate, you can change it. There's nothing for you to worry about. We've got this. It's really actually unhelpful and doesn't meet them for where they're at. So just having that metacognition of your delivery, communication, and also to your energy can sometimes be helpful and improve you as a clinician or as a pain clinician. So bioplasticity, we used to say that pain is unavoidable and suffering is optional. When I say tonight it's about hope, we now say that pain can change, and it changes over moments, seconds, weeks, months, and years. If there is a car on a mum's baby and she's got a broken leg, her pain will change quickly depending if that baby is there or not there and the threat is there. So our body can do superhuman events, but also too, people need to understand that it's fluctuating and it's in this state of homeostasis and change all the time. So we used to say that change is possible, and now we say that change is inevitable. And it's not how we, but not how we change is not, sorry, how? What I'm trying to say is it's going to happen anyway, but we get to choose what inputs we put into our system generally to see what adaptations it comes. So I'm trying to sell that they have some control over their pain, even if it's not how they think they used to have control. So if we go back into pain developing hypersensitivity system, this is when I might talk about the cup model. I feel like all of us in the room understand this, but it's sometimes tricky to get clients to understand this. So I will say something like, and hopefully you guys can all see this. I might draw something here. So I might draw a cup. Can I draw a cup? Hopefully I can, tools. And often in my room, I've got a whiteboard. I find it helpful because I am a drawer. So I would say, hey, we've got a cup here, and this is the size of the cup. In the past, maybe I'll say something like, your cup used to be this big. This might have been when you were really fit and you didn't, you were doing all that exercise stuff. But right now, this is the cup that we're dealing with. Because they might have talked about a life lost. So I'm acknowledging their past experience by saying, hey, yeah, but we're talking about this cup today. This is the old cup. And potentially we can get back to that cup. But I'd say what we want to do is think about all the things in your cup that increase the sensitivity of your nervous system. And again, thinking about bioplasticity and how our body's responding to input and change. So I noticed you said one of your aggravators is when you don't get enough sleep, your pain increases. So again, this is me spurting their words back at them. I also noticed, and I might say this in jest, your mother-in-law came last week and you also said you had a big flare-up. Do you think she's feeling like that relationship or person's filling up the cup? And often I might pick someone who, like, I know I can have a giggle with, because I'm also hoping to encourage playing curiosity and openness. Reading the room. A lot of the women that come and see me are perimenopausal or postmenopausal, and they will say, oh, my hormones are a massive factor. So I will write each of these out. I don't know how I'm going to do it with this, but it will be like hormones. I might say stress, and I'd say, what else do you think fills up the cup? I know that we were talking about it's worse with sitting, so we're thinking about mechanical modulators of pain, and that might be, I don't want to say it, but it might be something like your posture or your movement variability. What else do you think will fill up your cup? Rachel, is that how you would use a cup?
Yeah, I think so.
Yeah. And so then I say to them, all right, we've got two things that we're going to change, and I'll get the whiteboard eraser out. I don't know how I can do an eraser here. So I'd say we're going to change two things. I'm a physio, so I'll also work on strength and capacity, etc. So we're going to work on the size of the cup. We're going to slowly see if we can increase your tolerance to load and capacity, but also too, did you know by learning about pain and learning about the sensitivity of your nervous system, the more you understand it, the more you'll be able to potentially, while we work together, dial things down or take things out of the cup that may, I don't know, also contribute to your pain. Now, there's some things that we can't take away, and it's just a part of you. Your genetics, for example, might fill up the cup, so we can't change that. But there are things in this cup that we could be able to change. Hormones are set, but maybe let's have a chat to your doctor and potentially let's look at some HRT. So there might be other examples. I want to make sure I stay in the scope of physio, but that's how I would tackle it. So firstly, reduce the things that might be filling up the cup, and then also to sell hope and hopefully change behavior and perceptions later that allows them to tap into bioplasticity so that then they can change the size of their cup or capacity. Does that land with anyone? I'm just going to mindful. So all the processes that are happening that underpin pain are open to learning, and I'm trying to get the client to understand that. And the longer you have pain, the more easily you get that pain. So that's when I might say, like, the longer you've had pain, you've told me that you're unable to do as much stuff as what you have in the past, your cup or capacity is slowly reducing. Is that fair? So we might have that conversation. Sometimes we might show them. This is the Tame the Beast. It's a beautiful little short story and something that I'd really encourage you all to read, to watch. But sometimes I'd send that to someone, or I might watch it in a session. And then what I would say, so the effects of bioplasticity when pain persists. I don't draw this graph, but it's still a nice graph to use. So the capacity of the body, strength, endurance, and skill reduces, and the sensitivity increases. The way I talk about this with someone is I might say something like this. Right. I might go, hey, it sounds like, and this is sometimes when I'm introducing that idea of pacing or boom bust, it sounds like, so if this is capacity on this side and this is time, it sounds like you've been doing this for ages. And now we're down here. And so that's when I'm showing them that, like, they might go nuts, and then they might flare, and then they might have a few days where they do absolutely nothing. So I say what we want to do, and again, I'm selling hope and showing how they can use bioplasticity to change their symptoms. I'd say we might find a safe line, and I'm mindful this might be really frustrating for you. And our safe line, we want to be up there, but it actually might be down here at the minute, and that's okay. What we're going to do is work together to find something where we can slowly try and increase your capacity in a safe way that your body and nervous system feels like a safe. And then over time, we're slowly going to push that so that then it comes up like this. And a lot of people might say, yeah, I've tried that. It's really hard. Or I just can't handle stopping when I'm feeling good. So I acknowledge that that's a really hard challenge, and that might be something that we work on together. The other thing that a graph or an example I might use with someone is I might draw this kind of graph. Oh, sorry, guys. I hope this is helpful for you guys. I might draw something like this. So to acknowledge bioplasticity and how tough it has been for them, and also to, again, selling hope or showing them there is a way out or a way to change, I might do something like this. I would say, again, this line here is our expectations of recovery are often like this. All right, I've gone to see Jess, the physio, or Rachel, or whoever, and I'm doing the things that she's talking about. And this is where I expect my function to be. So this is function right up the top here. And I might be thinking, yep, right, why I should be able to function like a normal human. You would have heard lots of clients say things like that. But I can't even do the basics well. And so I'm doing all the things, what's happening. And I'd say, but their reality, and this is what they're experiencing when they come and see you, this is the line of reality. It's like this. Up and down, up and down, up and down, squiggly line, backwards line, whoa. And then I show them that this curve here, I am a real science and data nut. I often say this curve here is logarithmic in nature. So for those who do remember, I don't know, maths, logarithmic, it goes up exponentially, but it doesn't happen over time. It just happens. And what I will tell them is that right now, and this might be when they come and see me, and often I'm a very dramatic person, so this helps me because I will feed into my drama, hopefully bring them with me. I'd say you expect right now, you've been doing the thing, and you expect yourself to be up here. But right now, your reality is that you're right down here. Now, this here is what we call, this is from James Clear, you know, the guy who wrote Atomic Habits. This here is called the Valley of Despair. So this is where I'm like, this is quite dramatic. This is not a fun place to be in. When your expectations are up here, but your reality is down here. And this is how I talk to a client. I want you to remember this conversation, and I want you to put this graph somewhere important I want you to remember that this is a logarithmic curve and that over time, this is going to exceed your expectations. It is not going to be easy. It is not going to be without flares. It is not going to be without pain. So I'm really honest. But over time, if we keep doing the things, keep trying to dial down your system sensitivity and keep increasing your capacity and slowly work on some of those sticky beliefs that maybe aren't serving you or sticky nervous system responses that aren't serving you, then this can be our outcome. So again, hopefully not too much, but I am selling hope. Coming back to the group now, how does that land? And is this something that you guys can talk to a client with, like about? Could anyone imagine themselves having this conversation with a client?
Yeah, I like that. Yeah, kind of ties a lot of things together. And I like how that was a pit of despair. Like it kind of just, I guess, validates what they're feeling, but where they want to be.
Yep.
Yeah.
Yeah, and also too, like I'm a really dramatic person. This is authentically my way of explaining it, and I don't want you to say like this is the right way. It's what I've really struggled with pain education is like you will learn one way, and that is the way.
Yeah.
The best way is the way that feels authentically you. Rachel, have you learned anything like this in your studies to date, or could you talk like this to a client?
Yeah, I guess like especially the like that boom bust, I feel like
Yep.
that's taught pretty well. I feel like I use that. The exponentially like function where your reality is. I haven't heard that like, concept before, but I feel like I could use it with a patient. Yeah, it's good.
And again, mate, only if it's helpful. What do you guys reckon will be some of your challenges delivering some of this stuff?
Well, I would think like for me, like sometimes even having confidence, like you're telling the patient, yeah, if you just keep plugging away, this is the way to go. But like, what if you told them the complete wrong thing and I'm not even like helping them and like they're plugging away and they actually won't make any like gains because we're doing the wrong thing, you know, kind of like that.
Yeah, no, I feel like and do you know, that's a sign of a good clinician is reflective of actually like, shit, I might not be the best person for this person to see. Often I might be using something like a traffic light system with a client. I've got a really messy brain, so I often try and create rules for myself. So I'll talk to the client and say, hey, let's give this about 3 sessions. Each time I'm going to ask the same question. Do you think you're same, better, or worse? So I'm not asking about their pain. And I will use same, better, or worse. I'll document it and I keep all my notes the same so that then they say, oh, Jess, I just feel like this is a waste. And I'd say, yeah, mate, it must be so tough. But the last 3 sessions, can I just get my notes up? You've said that you were better. And I'm mindful you can go like this, but I'm looking for a trend. And then I will draw out that graph and I'll say, do you reckon we're in a bust at the minute? Like, and then we might go and unpack all of the other shit that's filling up their cup and is increasing their allostatic load. But sometimes you're right, Rachel, sometimes what I'm doing might not be helpful, especially for people who've had a trauma history and we're bringing up some of these sticky beliefs and we're unpicking a lot of things. A lot of the time people can have flares because they're reliving trauma or they're having to process all this information that can potentially be really dangerous for their nervous system. Especially to a lot of my clients are going through other diagnoses. They're finding out they've got ASD, ADHD, and they're also dealing with a lot of pain. So they're coming to me in this massive health crisis. Sometimes doing pain education and physio is just not the right thing. So I'll use the 3 sessions. And if they're feeling like, oh, it's just kind of the same, I will have that direct question. Do you feel like this is helpful or harmful? And I'm like, I'm not offended. My job is here to help. Maybe I'll just have to guide you to see someone else to keep you on the right path. So I'll have those conversations really transparently. And hopefully I'm creating, which is all through the literature, a true therapeutic alliance. Yeah. Does anyone else, Janine, do you have any questions about this? Or Danny?
No questions. I really like the graph. I use that kind of analogy quite a bit in terms of it. You know, it's not going to be linear, and I'll often use that with perhaps helping them create like a flare-up plan. So, when things go to crap, and they probably will, this is what you're going to do. And so that when they get to that point and it goes downhill and they just want to go into despair and nothing helps and all the rest of it, they've got steps already there to say, all right, no, I'm going to do this, this, and this. And whether they need to come back in for an appointment if they're really sort of unraveling with it, or whether they can just sort of eventually start to manage those things on their own a bit more. I find that that's really helpful if you can kind of explain, no, it's not going to be linear. They're going to be bad times. Here's our plan for when it is a bad time. You get in front of it.
Absolutely. I love that conversation. And sometimes too, if I really think someone is going to struggle and fall off the bandwagon, I might even directly say to them, and I might use you as I'd say, Danny, this is going to turn to shit, and that's okay. Again, I swear a bit, so just again, pick your language. What would be helpful for you when that happens? And what is my role when you fall off the wagon, or if you do have a flare, what would be helpful from my point of view for you? So again, got to be really careful about therapeutic boundaries. It's like sometimes I might give an example is where you do lots of reach outs and calls to our clients in private. I'm mindful when I was working in public, the level of support probably wasn't there because we were just absolutely smashed with lots and lots of new clients. So in private, I asked permission, what's going to be helpful for you when you do flare? Is it a text? Is it a, hey, you missed your appointment, I'm thinking of you? So there's no pressure or no judgment. But often I like to, like you said, Janine, front load and have those conversations before they happen. Because too, when it happens, they're like, oh yeah, we talked about this. And then they know that I've got permission to do the next thing so that there's an ally in their treatment plan. Again, you want to be careful that you're not the rescuer or they're creating a dependency. But I'm mindful if all of you guys are here and keen to learn about pain, I'm pretty confident that we're not going to be creating dependency or guru effects where like we have to swoop in and save the day and now it's all about our egos. So I'm mindful that people who are attracted to help clients who are in persistent pain often are trying to get self-management and get them to guide their kind of pathway. But yeah, sometimes that permission seeking has been helpful, especially for some of my clients who've had ASD, who pain process and process things really differently. It's been really helpful for me because I actually don't know what they need in the moment when they do fall off. Were you going to say something, Monique?
No, I'm a bit like you, like I'm quite
Yes.
I'm just nodding along.
No. So we'll go back. So we covered the cup and we were talking about bioplasticity. I'm just going to go and finish off this lecture. Just between you ladies, well, and whoever's watching this, I'm playing my first game of netball tonight after I have 2 young kids under 2. So I can safely say I don't think I've played netball for a very long time. I'm actually a bit nervous. Anyway, we'll see. I'm hoping that I will finish. What I'm saying is we'll finish crisply at 8:30 so I can do a moderate warm-up and don't tear my calf. Anyway, fingers crossed. So clients will then ask with bioplasticity, what we don't want them to feel like this is their fault. And often they have been told by professionals. So sometimes the dialogue I hear is, I've done this to myself. It's because I'm an overachiever. It's because I just keep pushing. Again, I am working with like a very health literate crew. Sometimes the language with lower socioeconomic, like lower health literacy, it might be, it's out of their locus of control. So they might say, yeah, but the surgeon did this to me. Also, like it might be forced. I will try to come back. How did the pain system become overprotective? So still acknowledge there are other reasons for potentially their why or their reasons, but we will then I'm trying to live in the present and the future with them, acknowledge the past, but move forward because that's what we can control. And we know that, again, bioplasticity, we can change depending on the inputs we put into the system. So again, still thinking about that message of hope. So sometimes I'd go into this. Sometimes it's helpful, sometimes it's not. Probably I don't go into this too much, but sometimes the health advice you've had or perceived is that rest is helpful, and we need rest to help how healing occurs. And there's a misconception that an increase or maintain pain sensitivity because something's wrong. But we know that pain doesn't always equal damage. And I might say that 50 times in a session. Our pain is really complex. Again, I don't use a neuro tag model too much, but if you did want to jump into it, please watch that lecture. Because Lorimer will go through into this, and he also goes into, I don't use this one, so it's not, I'm not that good at delivering it, but this is the protectometer. I think about this as a dial, which we're going to go into the dial one next session. This is a cause of allodynia and hyperalgesia, which I kind of quite like because these are known terms. So this is a reduction in pain threshold to a stimulus, and this is painful things become more painful. And we can go into these in depth with the client if they do really want to know. So how do they how does hypersensitivity prevent recovery? So what I suppose they're trying to say here is this is like the other side of the bioplasticity, and that when I'm educating someone, I want them to know that it's not their fault. It's a very complex system. And again, I don't draw it like this, but I'm thinking it's about your hormones. It's about your gut microbiome, your inflammation levels, your genetics, how you feeling at the time, how much threat or stress you're in, how much inflammation, like all of these different things are factors that will dial up or dial down your sensitivity. And I just keep saying to them, it is not your fault, because I want them to have autonomy over their pain so that then they can change, or we can go back to that hope that they can do something to change the output. The last thing I wanted to go over in this lecture here is the other way to do this. Last one is they go through this, it's about their way of doing that graph is like this. And you might have seen this in the past. It's like this is recovery. And I really like that the typical pathway isn't a straight line, and that to do this, you need energy, insight, and tactics. I can help you with the tactics. I can't help you with the energy, but we can work together to help the insight. So that is how they sell the same thing in a different type of graph. In terms of going back and wrapping this up in terms of bioplasticity and hope, it predicts recovery is possible, and I love it that it's scientific. We can see it in evidence all through our body, so that, and also too, people understand it because they know that if they don't do exercise, generally they put on weight. Like they can see bioplasticity working all the time for and against them. And so if we can show it is possible, then I'm hoping it is our in. So it's our knocking on the door saying like, yes, you could also show that recovery is possible. But again, it might not be a way that they had thought. Instead of it just being concentrating on the muscles or the bones or their quote unquote injury, we're going to work on the whole nervous system, because you're not just a break, you're not just a disc bulge, you're a whole living, breathing organism. And again, I might say that again and again and again and again, because I'm using that repetition to help with learning. Does anyone have any questions about that? I can stop presenting. Your homework for this week is, last week we tried to give this education to a client, which was like the Twin Peaks model. This week I do want you to have a crack of talking about the cup, And also too, thinking about how you communicate hope to your clients. And I want you to not think too deeply, but at least reflect once between now and the next session is, what's my delivery like? What's my communication strategy like? Super weird, but what's the room setting and the environment like? What's my body language doing? And am I meeting or matching the person where I'm at? And then how am I giving hope in a way that is meeting them? And then you can, like, again, I use hope and bioplasticity as intertwined, but see what lands for you. Does anyone else have any questions about that or curious thoughts? No. If you don't have a client who has persistent pain, I still want you to reflect on potentially if you guys had a moment of time when you were in pain or discomfort or dysfunction, and then how then you or someone else gave you hope and what was helpful for you. So I suppose, like, if you don't have clients, that could be helpful or practical terms. Next session, we will go on to the dial, the protectometer. I'll show you the way I do it with like DIMS and SIMS, and how I would get someone to brainstorm that in there. The thing that I've found most powerful with this stuff is the whiteboard in the room and having 2 whiteboard markers, one for me, one for the client, and scribbling it together. I learned this from watching, who's the crazy, David Butler. He does this a lot. And I just keep thinking of what people take in from a session, and also too, you guys as learning, the more active you can become versus just listening and being didactic, you're going to get way more out of it. And I feel like our clients are the same. We are teaching them. Often I'll have these conversations in the subjective, and I might use my hands-on skills of a way to say, hey, I'm putting an input into your system and I'm working on your bioplasticity by putting in this stimulus, but it's even more important for you to put in inputs in systems. So that's how I'm kind of fitting in the manual therapy. In our 4th week, I'll probably talk about that a lot more after we've gone through this last kind of theory, and then I'll talk to about like where or how we clinically reason when we touch and when we don't. If that's helpful for you guys, I don't know. Awesome. I hope you guys have a really good week. I can stick around for a little bit if anyone does have any questions. I will ask you guys before we start recording next session to bring a client and a case so that then we can talk through a problem, solve it together. So think about how you're going to apply these principles, but also to start to have in the back of your mind someone who's a bit stuck. Sick. But thank you all for taking the time and coming tonight. I hope that it was moderately helpful, or it might change practice a little bit. And I'll see you guys next week. Also, between now and next week, tomorrow, I'll put on those extra little lectures that I send out to clients that are super, super helpful.
Thanks, Jess.
No worries. Good luck.
Thank you.
No worries.